Welcome, everyone, and thanks for participating in this talk. I'm Cecilia Mascolo, I'm Professor of Mobile System at the University of Cambridge. And today I would like to talk about my research, and this is just to set the scene. Generally, I'm interested in trying to find ways of sensing behavior that is difficult to generally sense. So somehow it would be good to have continuous input for some diagnostics or some well-being aspects. So when you go to the doctor, often you only get a sample perhaps of your heartbeat every time you go. Wouldn't it be good if we could get input from your heart continuously? There are already techniques that do that. That was a simple example. Then sometimes there is some information that doctors would like to obtain that often requires the user input and attention. And can we have a proxy for that so that users don't have to continuously input their data? Or sometimes we have come up with sensing techniques that are good, but they are expensive or they are inaccurate. And can we get better? Can we do things better? And obviously, every case where we have devised a way to get input from our body, but that's invasive or it could be dangerous for the person. So can we have other proxies for that? And so in this talk, I'll give you some examples of my research in this area, and I will highlight the limits and perhaps the challenges of doing such thing. So the first example I want to give is about fitness. If I was in an in-person audience, I would ask you to count the number of the hands that are raised if I ask you if you have done this fitness test ever in your life. This is a test to measure your VO2 max, the volume of oxygens that your lungs can intake, and then it's transferred to the bloodstream to your muscles and then transform into energy. So it's a good proxy for fitness. But as you can see, it's an expensive exercise, both at the level of it's strenuous on the body, and as well as it requires all this equipment. So it's not very portable and not very scalable because it's not very affordable. So people have come up with techniques to proxy this kind of information. Fitness is a good also itself is a good proxy for cardiovascular health, and cardiovascular health is a big deal these days, and it has been recognized as one of the most important to take care of for population's health. So proxies for fitness, or then proxies for health, are have been simple things such as questionnaires asking you how many times you exercise, and those are also used in combination with demographics and weight, as well as recently with resting heart rate information. So this have been an example of estimates that do not use continuous information. However, they're not super accurate estimates, and other have tried in small scale studies to come up with better estimates. In this work that we are producing, this is new work, right? This is a keynote, so I can talk about the work we are doing rather than the super published work. So this first part is not yet available. But we have tried to use data from a large cohort to monitor and track and see if we can predict fitness in a cohort. And I'll explain a little bit more about the details of this. So the study design is that there is a group of people that epidemiologists in Cambridge have been tracking for years, and it's called Felland, and it has 11,000 people. They have been tracked by being giving them some VO2 max test, the one that you have seen, getting some anthropometric measures such as weight, height, and BMI, and some other questionnaires of activity, as well as for 6 days wearing a chest strap sensor that had an accelerometer and a heart rate monitor to collect this continuous data. One important thing is that this cohort has been tracked, and 7 years later, a smaller cohort, subset of those, has also been tracked in the same way. So there's two cohorts, two groups in the same cohorts. And we have then applied some machine learning to the data with the challenges of having such large data and such high level of information, especially on the wearable data side. And we have tried 3 tasks. I will talk mainly about the first 2, trying to predict cardiorespiratory health by using this data, and instead of using the VO2 max. The VO2 max as a test is the ground truth, and we try to use the accelerometer plus anthropometric measures and movement and heart rate data to predict the VO2 max and see what error we have. And then we've also tried to predict the fitness direction. Will someone become more or less fit, benchmarked with respect to the age, with respect to that. And yes, we've looked at also how the model adapts, but I won't talk about that. So just a very quick set of results about that. It looks like, considering data from wearable devices, so the fact that we have an accelerometer in addition to the resting heart rate and all the measures that one can take as a spot check, anthropometric measures, is a better way. So the error of our model with respect to the ground truth is lower in this case than in all the other cases, just using the metrics, just using the heart rate, using both, and using also the wearable sensor data. So there's a good result here showing that it's good to actually have this wearable data, and this is a large-scale study that proves it. So it's quite interesting. The results are also visualized at the bottom here. As you can see, we tend to underpredict the VO2 max in some of the cases. So there's more an analysis that can be looked at if you're interested. The second task is about predicting the change in fitness in 7 years. As I said, we have this smaller cohort. Now, here we have divided, so this is the distribution of the change in fitness. So 0 means that people have not changed the VO2 max level at all, or at least a little bit. The middle quantile is the one that hasn't changed much over the years, and you can see it's most of the people. But our techniques are actually quite good at predicting the extreme. So a task that says, are you in the middle or are you in the extremes, does quite well here on the right axis, a right figure here. You can see that we have a 0.4 prediction in a binary task that is attempting to predict if someone is getting really into the extreme cases. I will now switch gear and show you another example of sensors that can be used to understand health. This is obviously, we've seen that in the previous case, it was an example of large-scale, well-established sensor techniques that our community has been using for years, and now has been brought into practice into epidemiology to try to see if we can estimate population health and population fitness. And this is our attempt instead to use the next generation devices and see if they could possibly lead us to detect health and behavior. This is a paper that in fact is published, and there's an indication at the end, at the bottom of where you can find it. The idea here is wearables are seen as the next smartphone in terms of what they could be and the kind of penetration and importance that these wearable devices can have. Already the prediction for 2022, which this is already kind of almost there, is that they are the main wearable being worn. And I think the pandemic has just made things worse. I'm wearing them all day just to talk through Zoom. Now, the underpinning concept that we're using in the study to talk about our trying to detect behavior is the fact that some of these wearables have an inner microphone that is blocked behind this rubber bit that goes inside the ear. And this rubber bit creates an occlusion effect, which amplifies sound waves and amplifies smaller frequencies. And this is helping us to detect some vibrations, which can mean something for our ear. And so the inner microphone is able to get those. So what are these things that we're able to detect through this process of occlusion? So we notice, first of all, that there are a number of activities that we could try to detect. These are simple activities. And we notice here that on the top, you have a person still and a person at the bottom, in the bottom row, and a person moving the head. And we notice that the two graphs, the two rows are very similar, which means that for all the activities, the head movement has little effect on the data, which means that great, we can detect activities through this concept of occlusion effect, and then understanding the bone conductor of our body vibration that can then repercuss into our ear and amplify this by this occlusion effect. So it's possible to detect these activities. We have made a little prototype to try to understand how these activities can be in fact detected, and if we can then apply some methods, some analytics methods. None of the existing earbuds allowed us to play with this. We couldn't get the raw data, therefore we built our own simple prototype. And what can we do with it? Well, the first thing we tried was to try to step count, to recognize gestures, and obviously recognize activity. I've already given you a glimpse of how well we can recognize activity. So here is because I like videos, here's a visualization of one of the lead authors in this paper, Dong Ma, walking. And then there is a this is the visualization of the movement. As you can see, as soon as it starts stepping, then we can, it is walking, and this is the blue and red lines are the left and the right, and I should say about the green line. And this is like the final stepping when he's really stepping really hard. And as you can see, the green line is the in-ear microphone. So the external microphone in the earbud is not detecting this movement, while the other two, left and right, well, the in-ear is obviously in both ears. This is plotting just one, but is detecting this movement. These patterns are very, very clear. Oh, sorry. And this is again our experiments to detect gestures. So Dong will be tapping various points on his head, and then I'll play this other one, and you can see that it's detected the first, it detected now that it's doing that, it's detecting the third time. And it is possible to actually detect one from another, especially perhaps as a class of quite different gestures. Now here is the general performance, if we want to talk about that. So starting from this picture, you can tell that by just using the left or the right ear, or using both, the performance, precision and recall using two different classifiers improve. Logistic regression, SVM, they improve. So it's good to have fusion of the two channels, of the two ears. The confusion matrix show that we're able to quite well detect the various activities. There's no confusion between the activities. And the table here shows by the different columns, step counts, activity recognition, gesture recognition, how we do with respect to other sensing. So if we were sensing with just an accelerometer, with the head moving and without the head moving, these are the percentages. So it's detecting step would work, step counting would work, but then activity recognition decreases considerably with head movement. Gesture recognition too. The external microphone also doesn't do very well. Our approach with inner ear, which has been tried with head movement, with or without music, works very well and is able to have good performance. Now, I'll say a bit more about this performance, especially with respect to personalization. So On the x-axis, you see the different subjects on which we have tried this, and the two colors are precision and recall. The first thing you notice is the low level of performance here, which means that for some of the users, the approach didn't work that well. And so what we tried is to add a little bit of personal data. So here is, in the first figure, this is just the model trained with data that is not of the same user. So this is data of all the other users tried on user 1, tried on user 2. And for some of the users, it doesn't generalize very well. And doesn't, I should say, personalize very well. However, if you look here, the purple and as well as the green, if you add just 10 personal samples to these users, you see that even number 2, purple, goes up to 90% in performance in both precision and recall. And of course, if you go higher in the number of samples, this is the final graph that shows that if you increase the number of samples per participant, you go up to almost 90, 95 very easily. But already here, the number 10, we're above 90%. So this is really working well. We've also tried, and I'm not showing it here, you can refer to the paper for this, trying the different activities on different type of floors. As we're relying on bone conductance, so vibration generated by that, by vibration that is then transported by bone conductance into the ear and then amplified by this occlusion effect, we have tried to see what we could do with different floors and different shoes as well. So that is in the paper and tells you a little bit about the performance that we have achieved. So one thing we're trying now is go further with this technique and see if, in addition to activity, we can use the inner ear microphone to detect other biological signal. And the first one we are trying is heart rate. So this is initial work that shows that, in fact, the inner ear microphone, this is an example in static mode, stationary mode, is able to detect the heartbeat. And you can see here very, very well graphed over time. And at the bottom, you can see our comparison with an ECG, so a ground truth, over time of the heartbeat and our error. In the stationary case, it works really well. And as we add movement, this becomes a bit more erratic. But you still have a reasonable error, we find, with respect to the ground truth. Obviously, ECG is not something that would allow you to, no one carries ECG throughout the day. I mean, we do that sometimes if we have to have our cardiac health, then the doctor would give us this Holter monitor that you would carry, but it's not something that is very much embedded. It's embedded, for example, in the watch, but then you have to stay very still and do your test with one lead ECG. So this would be something that instead your microphone ear, your microphone in the ear would then be able to do. And we are exploring this capability these days. The last thing I would like to talk about is something, again, that is not investigating new sensing technology, but is investigating what we can do with some data that can be collected in large scale by the devices that are already in the pockets of many. In other words, this is an app that we have produced for phones in COVID times. And I can give a completely separate talk on how difficult it was to push out an app with COVID in the title through the Google Play and Apple Store in COVID times. Obviously, these companies are doing the right thing and trying to really be quite precise and scrupulous on which app they let on the market. And we had to go through all sorts of authentication steps to make sure to really tell them this is an academic study and it's legitimate, and we're truly trying to help here. And so what does this app do? Well, the URL is over there in case you want to see the project in more detail. But in addition to being just a survey app that asks the user for their demographics as well as their symptoms and their medical history, we also collect audio. So we ask the user to breathe into their phone. So they would have their phone like this, and they would breathe 5 times, and then cough 3 times, and then read the sentence on the phone screen. And all this data will be collected through a microphone in the device and then sent to servers. What's the holy grail here? Well, the idea is that audio it has been started to be established that audio could be a good proxy of our health. Our voice, our cough sometimes, and our breathing can tell a lot about us. So for COVID, but also for other perhaps chronic diseases, it would be good to provide scalable, contactless, affordable, but also I would say sustainable testing. The current COVID tests are quite, use and then throw away. They can be quite invasive, and they possibly don't scale as well as a digital solution could do. It's also, this one is contactless, so people could repeat it, and it could be good for progression of any disease monitoring. So just because we're coming to the end of this talk, to some extent, this is the last part, I want to talk about some numbers. These are people who have given us data. They have generated a number of samples, and there are more than 30,000 users. They've given us their information, and well, they obviously can see from the graph on the location. They could tell us that they didn't have to reveal their location. So the most common location is actually none. In addition to this information, we collect their list of symptoms as self-declared, so it's crowdsourced information. We collect data about their test. So we asked them when they tested for COVID, if they did, and what was the result of that test. So all of this, the challenges of this data is that it's self-reported. So obviously people lied, people answered incorrectly, just involuntarily. But the good bit is that there's so much data that we find that there's some good to do. The idea here is that some of the studies have highlighted that perhaps voice and coughs could have features specific to the disease. This is an example of a healthy cough spectrogram. You see the frequency, and the COVID cough spectrogram, COVID voice, spectrogram, healthy and COVID. And you can see, even just by the eye in this particular case, the various harmonics are very clear in the first one, and there is a difference in the high spectrum, high frequency ranges in the two. And so features like this could be picked up by models and then used to distinguish. Are we doing it right? Is it working? Well, I can point you to the URL and to my webpage. There are some papers there that have started to be published around this by our group, and you can look at the results. The indication is that we're going in the right direction, but obviously we might need more data to distinguish between diseases. Some diseases, our data, there was no flu season in these 2 years. So we don't know if we'll be able to distinguish that. We have some indications that the model is not confused by data from asthmatic people, and we could possibly distinguish that. And this, in a way, could be used as a technique to do some sort of pre-screening, even if the performance weren't that high, because it's easy to repeat, it's easy to administer, it scales, and so it could be used in combination. And therefore, I think it's promising. But the most promising part of this is the kind of repeated user data, the longitudinal data that we're trying to collect. So here is a graph showing the number of samples that each user has given us. And you can see up there is one user that has given us more than 250 samples over the collection period. And I always thank them in any talk I give. But even other users are giving us more than one sample, which means that we have a relatively small but still solid sample of users on which we can study, and we are studying the progression. And here is a thing, I think, where a digital application could make a real difference, because progression would possibly indicate if someone needs to go to the hospital or if someone is on right track to improvement. And the personalization aspect involved into this could make the general performance result of the one-off tool much better, because all of a sudden you hear a voice, you learn about that person, and you can do better. Also, being digital, the fact that the person needs to continuously repeat testing doesn't mean that it's invasive, doesn't mean it's uncomfortable. So it becomes really a useful thing to have and to do. So with this, I would like to pause and ask for your questions. First of all, though, I would like to thank my team who has worked very hard on these topics. You can find our work on this webpage, and I would like to finally thank my sponsors, the European Research Council, who's funded this research, and Nokia Bell Lab, with whom we are doing some part of the research. Thank you very much.